Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFAL York Operations Coordinator. I would like to officially open the second 2024 session of the Emergency Management in Hospitals and Healthcare Speaker Series, presented in partnership with the Thunder Bay Regional Health Sciences Center. I'd like to begin today with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have long-standing relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Tkaronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. The territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event, our participants may be joining from various locations, so I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speaker, and our participants from around the world. Welcome to our webinar. Without further ado, it is my great pleasure to introduce our moderator, Misha Richard. Misha Richard is the current Emergency Preparedness Lead for the Thunder Bay Regional Health Sciences Center in Thunder Bay, Ontario, Canada. In this role, she acts as a subject matter expert, assisting with the development and maintenance of emergency management governance, training materials, and exercises. Misha also volunteers as an editor for the Canadian Journal of Emergency Management and is happy to be a collaborator and facilitator for the CFAL York series. She holds a Master of Disaster and Emergency Management degree from York University and bachelor's degrees from Western University and Brandon University in the focus areas of political science and disaster studies. Misha, thank you very much for moderating today's session. The floor is yours.
Excellent. Thank you very much, Francesco, for kicking us off this morning. And thank you to everybody who is joining. I want to start off with just a really quick housekeeping to everybody before I introduce our excellent speaker today. So I always end up having to do the little poke that we've got our chat. It's active right now. I can see people populating where they're from, and we really appreciate seeing this information. So welcome from multiple time zones. But if you have questions during today's presentation, we ask that you actually input those in the designated Q&A. So I'll be monitoring the Q&A. Our speaker is, open to having questions throughout the presentation. So please put them in there and I'll try and raise them as time allows. And we'll also take time for questions at the conclusion of the presentation as well. So now that the housekeeping is over, I can get on to the introductions. So welcome to Keith Hansen. He's the co-founder of the Association of Healthcare Emergency Preparedness Professionals, which kicked off in 2014. And he maintains a leadership position in this international organization that's dedicated to the needs of healthcare emergency managers. So AHEP, as it's referred to, is dedicated to moving preparedness forward through the development of professional standards, certifications, education, and training. Keith is also an instructor in the Emergency Preparedness Program at the University of Nebraska Medical Center's College of Public Health. He also directs the Center for Preparedness and Emergency Response Solutions. Keith is also somebody who's conducted strategic and tactical planning, education, training, and disaster drills and exercises for Fortune 500 companies, higher education, government, local and state public health departments, hospitals, and emergency management agencies and first responders. He also serves as incident commander for the University of Nebraska Medical Center. So I could go on, but I'll stop there and I will cede the microphone to Keith to kick off our presentation today. Thank you.
Thank you, Misha and Francesco. I appreciate it. So as Misha said, I'm Keith, and I'm here to talk about professionalizing our profession, right? I mean, if many of you were around when this field not really started, but kind of gained some momentum, we've been other duties as assigned for many years, right? I mean, we started off with infection control nurses that were handed emergency management, or facility maintenance staff that were handed emergency management. And as time has gone on, we've kind of progressed, and that was basically the genesis of AHEP. My co-founder actually came up with the idea. This was not me, this was her. And she actually came out of an office one day about 16, or actually in 12 or so and said, why hasn't anyone started a professional association for healthcare emergency managers? She was a former infection control practitioner who really relied heavily on the Association of Professionals in Infection Control, on APIC in the US. And she had colleagues in the conference and things like that that really helped her get rolling in her field. And she wondered why we didn't have that in healthcare emergency management. So after she would come out of her office for about 2 years straight and say, why hasn't anyone done this? Why hasn't anyone done this? I finally said, okay, we'll do this. So we did. AHEP, again, has been around since 2014, and as we've grown fairly slowly. We've had pretty controlled growth, but we are really trying to provide resources to healthcare emergency managers, not only in the US, but now internationally. I mean, whether they're strategic or educational or operational or planning resources, all of those things are important, and lots of organizations have those resources, right? But they're kind of hard to find and kind of diffuse, for lack of a better word. And I'll come back to that. The other thing that we really try and encourage within AHEP is networking. All of you have your stories, all of you have your responses, all of you have learned lessons. And I think one of the issues in our field is that every time somebody starts new in this field, they have to relearn the same lessons that I've already screwed it up, right? I messed it up. I did it wrong. Why are we allowing other people to do that? And that's one of the issues I think we have in this field. So that's why this kind of professional association is important, so we can share all of those things that we've done, and not only the things we've done wrong, but including the things we've done well, so people can learn from those. Our goal is moving preparedness forward. And when we say that, we're not trying to repeat the wheel. There are other organizations that do emergency management and emergency management training. We're pretty specialized in terms of healthcare. I think it's fascinating when we talk to people in other fields and just mention the word chiller. If you're in a hospital, you know what a chiller is, right? Very clearly, know what it does, implications of losing them, all of them. Oh, my slides are no longer up. All right, thank you.
This is what always happens. We tested with success, took them
did.
down, chatted, and we didn't reshare. So I figured I would give you a poke before too far.
Thank you very much.
Confirming we can see. Thank you, Keith.
Awesome. Good. Thank you. So moving preparedness forward is kind of our mantra. We don't want to repeat the wheel. We've had questions from people about, oh, why don't you start a journal? It's like, no, there are journals out there. We don't need to do that. Why don't you do this or that? And when we look at these types of decisions and what we're doing in terms of professionalizing our field, we want to make sure we're not recreating the wheel. So moving preparedness forward is something that we say all the time in almost every meeting that we have. Is this actually going to do this for us, for our members, for our non-members, for this profession? It's really important to us. So MBO, membership-based organizations, we do a lot of the standard things that membership-based organizations do, right? A lot of people do these educational webinars. I mean, whether you're in Society for HR Management or APIC or whatever it is, they have educational webinars, they have a conference, they have online resources, community and networking, mentoring, leadership opportunities, publications, all of those things. And we do all of those things too. Those are very common MBO activities, and we check those boxes also. But I think one of the things that we've done that I think is really important, again, for the field, for moving our field forward, is addressing the missing pieces. We kind of came up with 5 areas where we think we have gaps, or we had gaps in healthcare emergency management as a profession. One of those is professional standards. What should a healthcare emergency manager look like, for lack of a better phrase? What should they be knowledgeable about? What should they be able to do? What should they know? All of that stuff. And I think we don't really have that systematized in any way. Again, back to my earlier point of we're relearning the lessons that other people have learned dozens of times. Verification of knowledge. Do the people in our field know what a chiller is? Should they? I think so. Yeah, I really think they should. So do they? do you understand incident command system? Now, whether you use an incident command system in your hospital or not is, to me, irrelevant. What is important is that you have a command system that your hospital knows and it recognizes and uses in a disaster, because it helps with response. It helps clarify rules and responsibilities, all that stuff. So verification of knowledge is very important to us. And I don't think we were doing that very well as a field. And we're trying to get better at that. And that's one of the things AHAP is taking on. Training standards. There are university degrees, of course, that you can receive in healthcare and emergency management in general. And we're starting to see more and more healthcare emergency management degrees and more public health emergency management degrees that are available. But what are the training standards for people that don't have those degrees? What should they know? What should they take? What should they learn? What books should they read? What what independent study courses should they take? All of that stuff. What is that base core of training that you should have when you walk on the job? Specialized resources. Again, there are many resources within the world of emergency management that are not specialized to hospital. Nobody else except healthcare deals with evacuation like we do. Medically fragile individuals, it's us. Nobody else does it. Community emergency managers don't deal with it. They basically look at the hospital and say, figure it out. And that's now on us. So what are those specialized resources we can provide? And I'll talk about those a little bit. And then again, what are the industry standards? They're very few and far between for the individual. There are facility-based standards. There are, what should your hospital have? What should your long-term care have? What should your organization have? But very little in terms of, what about the individual that's running this show? What should they have? So that's another one of our foci for AHAP. And I'll talk about each of those in a little bit more depth here, if that's okay. So professional standards. This was our really first big task taken on in AHAP, and it was a long, grueling, very intentional process that we went through. And the culmination of that process was the AHAP Guide to Professional Standards of Healthcare Emergency Management. What we ended up with was a list of what we consider professional standards that everybody in healthcare emergency management should be knowledgeable of. It's important for us to look at what standards we have, what are the categories of information that we really need to know about, and how do we then gain that information? How do we gather that information in a more systematic, time-saving way and effective way? We reviewed lots of stuff in terms of building these professional standards. We looked at CMS, for those of you that are not familiar with that acronym. It's Center for Medicare and Medicaid Services here in the United States. And they do a lot of their payment system here in the US for hospital and healthcare from the federal government. And they came up with an emergency preparedness rule that they expect everybody that they fund to follow. So that was a big thing that we looked at. But again, it was very much focused on the institution and not the individual. So a gap. Emergency Management Institute is something that our federal emergency management agency has, and they have all kinds of very good training in foundations and executive trainings and specific ICS role trainings and all of that stuff, strategic leadership, tactical leadership, all of that stuff. And they do a good job with it. But again, it's here's a training on this and here's a training on this, and that kind of gestalt, that big picture is kind of lacking sometimes when we look at those. And then we have something called the NFPA here in the United States, National Fire Protection Agency. And that organization has codes for, again, the facility, not for the individual. So what we had to do was we had to try to look at this information from these organizations and try and extract, okay, so hospitals need to be able to evacuate. Okay, what does that turn into in terms of a skill set for the emergency manager? So it was quite the process that we went through. And in that process, we came up with, this is not the entire list, by the way, this is a shortened version, but these are kind of the things that are, for lack of a better phrase, are reference materials in healthcare emergency management. independent study courses through the Federal Emergency Management Agency, for example. But there are also other documents that we feel our people, our healthcare emergency management managers need to be familiar with. And this is the short list. And as you can see, this is all over the map, right? There are a ton of these things. There is no single source of knowledge for our field. It's frustrating is all get out to have somebody that comes to you and wants to get into this field and wants to be mentored, and you can't point them to a thing that will help them. That's what we hope to be. We hope, this is a weird way to say it. We hope to be that thing. I probably need to work on that part of the presentation, don't I? But these are the standards, right? These are the things, the recommended pre-reads that we have for this. Out of those, we pulled 14 competencies. There are 14 things in the first draft, right? This is the first draft of this. This is a living document. There will be more. 14 things that we felt healthcare emergency managers need to be knowledgeable of. And that's, awareness and training. How do they conduct training? What training needs to be conducted? Communication. The first three things that go wrong in every disaster are, number one is communication, and number two is communication, and number three is communication. If you can't do that, you have a problem in healthcare emergency management. Compliance, wherever that is, whatever that compliance is with, whether it's in the U.S. regulatory agencies or Canadian regulatory agencies, or I see someone from Germany join the line, the German regulatory, if you can't comply with those regulations, you have a problem. So anyway, we went through these 14 categories, and we'll go through some more as time goes on. But these are the competencies that we identified in our first go round.
So then I'll interject, because you and I had chatted about this a little bit, this is a pretty comprehensive list, but it's not exhaustive. I noticed there's a couple of things that aren't listed. So business continuity, cybersecurity, even considerations for mass casualty response specifically. So is some of this intentional?
No, yeah, I mean, partly, yes, I'll give you the short answer. Yes, that was intentional. And then the reason we didn't include some of those things is that perfection was becoming the enemy of the very good. If we were to go with an exhaustive list, we would have been 2 more years down the road before we got anything out. So we thought, let's get out version 1. And in version 2, we will review all of those things that you just mentioned. Now, one of the considerations we have to make with that review is, for instance, business continuity. I won't mention names, but there's an entire organization that devotes itself to business continuity and training in business continuity. Is it different enough in healthcare for us to get into that? Or do we just say, nope, that's taken care of by somebody else, we're out, we don't need to do that? So, and I think there are multiple categories like that where we're going to have to look at those and say, okay, is that an area that we really need to work in or not? And the second thing I think is that some of those things like surge management or patient evacuation, some of those skills are not listed specifically, but may fall under response operations or another category that we have. So we're going to look at those other categories. Cyber, my good grief, I couldn't spell cybersecurity 5 years ago. And now I need to know the implications of if I get hacked, right? And what we do, and what I need to tell my hospital what to do, and all of that stuff. So we're really going to look into those and see what kind of training and information that we can provide that would be helpful. And where we just need to keep our nose out of it. I mean, there are other resources that people can get into. We don't need to do everything, I don't think, because we can't. We need to, again, perfection can be the enemy of the very good. And I think we need to strive for perfection, but I think we need to make sure that we're not delaying productive conversations and documents and activities in favor of perfection. So great question. You're absolutely right. There's stuff missing from this list, and it's pretty obvious stuff missing from this list that we're going to have to address. For each of the capability or competencies, excuse me, we looked at, for example, competency and awareness and training. What we did was we took that competency, defined a competency, and then we looked at capabilities under that, and then learning objectives under that. So we didn't just list the 14 things. We have some things underneath it. Now, we're going to work on a second version of this, and we need to work on a second version of this relatively quickly, because there are, like we said, there are things missing. But I think there are other things that we didn't get right the first time around. For instance, we have within there strategic planning, that a healthcare emergency manager needs to be good at strategic planning. Well, it's not just strategic planning. There's operational planning, tactical planning, writing emergency operations plans, policies, procedures, all that stuff. So I don't think we do it justice by just calling it strategic planning. So there's some stuff like that we need to tweak. But there's always going to be updates to this, and we will start our new version in spring. We'll start revising our first document in the spring, and we will be looking for feedback from people on that. What are we missing? What do we need to have? What do we not need to have? And how can we do this document better? Again, these are the same competencies. I wanted to give you a second look at them. These are the 14. You can download this competency document for free from our website. That's totally open to anybody and their dog that wants to download and look at those competencies. That is completely open.
Keith, I'll interject with one that's come up in the chat. I think we can probably chat about one at least at the moment. Somebody noted, and maybe this fits in with somewhat of the explanation that you were commenting on a second ago for why some of those pieces might not be captured if they're captured in other through other avenues. But somebody did ask, as far as, this is a great list of competencies, but maybe where you might see things like cultural safety or equity, and how that might fit in with what we consider as being a competency for healthcare emergency management.
Absolutely, yeah. And that would, currently that falls under social determinants and vulnerabilities, that competency number 11. So that's where we've categorized that. And if we need to rename that or I'm happy to do so. I mean, that's where that fits right now. And I think that is an important part of our job. We need to make sure that we're not only aware of that, but planning in accordance with that. So yeah, that's a good question.
I have one more, and then I'll let you carry on, and we'll see where maybe some of these can fit. But also now I'm seeing a bunch come into the Q&A, so it's actually a good opportunity. I'll keep stressing to everybody that I appreciate seeing the conversation in the chat, but if you have specific questions for Keith, please put those in the Q&A. So somebody brought up an interesting point as well, that obviously there's a huge variety in capabilities and capacity and sector-specific needs within healthcare, and wondering how we account for some of that when we think of things like one of the notes, the question lists is, emergency management for blood suppliers or dialysis providers or clinic systems and so on. So any thoughts about that before we move on?
Yeah, no, I think when you look at the breadth of healthcare, anything from small rural hospitals where we have, they're licensed for 25 beds, but they usually have about 3 patients. They still have the same regulatory requirements as giant hospitals, but their emergency manager is a 0.2 FTE. That's also the facilities manager and possibly the infection control nurse. I mean, there's a lot to think about when you're talking about all those different types of healthcare facilities and the specifics on those. And we've had the conversation about, do we get into dialysis healthcare emergency management and offer a specialization in that? And for me personally, that is so daunting that my knee-jerk reaction is no. Again, we got to start with this kind of broader picture, and then if we need to, we can actually go more specific and narrow that down. But I don't think our field can wait. We are way behind the curve in all this stuff already. So we need to kind of move this forward, and I'm totally open to maybe it's a large hospital and small hospital, different designation or competencies, or outpatient versus inpatient competencies or whatever. And I have no idea how to slice and dice that. That's a big question that may take a much larger brain than mine.
Thanks, Keith. I think you're good to move on, and we'll wait on a few of the other questions.
All right, awesome. So next boy, I took a lot of time on that first one, so I'm going to have to shut up a little bit. Verification of knowledge is kind of the second thing that we were missing in healthcare emergency management, I think, and that's why certification is important. Certification really helps others outside of our field feel comfortable with our knowledge base. It really helps advance the field. I think I keep going back to infection control. That was a big deal with infection control when you could become certified in infection control, and that is not an easy certification to get. If you are an infection control practitioner, that certification through APIC is difficult, and it means something when you see that in a healthcare facility or see that behind someone's name. So that's what we're trying to get to. We want it to be really a recognition that you're an expert in this field and that you should be treated as such, and that you should be immediately considered for that position if you apply for that because of the designation. It just increases our credibility. And the last thing we want is to have a certification that is easy, because then it becomes worthless. So that credibility of the field, I think, is very important, and we're getting there. It's getting more and more credible. We're seeing fewer and fewer other duties as assigned positions. We're seeing more than one individual per facility. All of that stuff is really important. So the healthcare emergency manager is what we've designated it. We threw around multiple names, but HCEM is kind of the way we ended up calling them, because that is kind of inclusive of not only the response part, but also the preparedness part and the planning part and the exercise part and all of that stuff. So that management component was important. They should be qualified to interface with hospitals, public health, emergency management, first responders, you name it. These are the people that should be the lead and should be in the forefront of all of that planning and very close at hand in the response. I understand that many facilities don't let their HCEM run the response. I get it. Here in the United States, we have local emergency managers that coordinate resources, but the governor of the state is technically manager of the response. So we understand that, and that's pretty normal, but we should be the right hand. When there's an issue, we should be on the short list for that speed dial. So what we came up with, though, was that there's no really single certification. I mean, as the question earlier alluded to, there may be specific certifications for the specific industries coming down the road. But for now, we kind of broke it into three categories. We gave it the basic, professional, and mastery. And each of those have different requirements. And the basic is really for kind of entry-level people that are getting into the field. You have to pass the test, and you have to work in healthcare. That's really kind of the two requirements, and that's why it's basic. These are kind of for new entry types of folks. The mastery requires 10 years of experience, response experience, large exercise experience. You have to contribute back to the field, meaning you have to have written a paper, or you have to have done a novel presentation or created material that moves preparedness forward. Right. So it's not just that you're not just going to pass a test and get this certification. And there's a reason we did that. Again, this shouldn't be easy. Can't be easy, or it's going to be worthless.
So then I'll jump in and ask, which maybe some folks on the line are also wondering about, is do you have to start at the B level, or can you jump in elsewhere? And does this mean that there's different test requirements for these?
Good point. Good question. So you can jump in anywhere. If you've got 10 years of experience, you can jump into the HCEM mastery level. If you're just starting, you might just start with the B. You don't have to start with B and progress your way up. The other question about the test, we have one test. At this point, we have one test, and we consider this the base knowledge that everybody in our field should have. And everything on top of that, we assess by experience. So either years in the field, exercises, responses, all of that stuff. So the test is really kind of the common denominator among everyone. And then everything else changes based upon that level. Others for now?
Nope. We had actually, I don't want to backtrack, but somebody was asking about the Emergency Management Institute, as you had listed some of these that have been consulted previously.
Mhm.
And it listed something called PL5. So they were saying they were trying to, so what was this? Noted around managing innovation and knowledge networks. And they weren't familiar and can't find this sort of via Google. So we might have to ask for some additional resources. But this is also a good opportunity to just mention to everybody that's in attendance. If we have questions that we aren't able to answer right now, you can certainly populate those and provide contact information. You can reach out to our coordinator, Francesco, and we'll make sure that we can get an answer back to you, even if we aren't able to close the loop on it currently in our webinar.
Okay.
So I'll stop there unless you can remember off the top of your head any other references, but I just wanted to put that one out there, seeing that in the chat and recognizing we might not be able to address that in this moment.
Yeah, I couldn't give you the link off the top of my head, but I will absolutely send that to you, Misha. It's in our question and reference standard database. So I will absolutely send that to you. So
Excellent.
certification. Yep. Go ahead.
Yes, sorry. No, I was going to say, Francesco just also, as our coordinator, has provided his email in the chat. So again, just a reminder to folks that are in there, you can direct questions to Francesco and we'll filter those ones and get you the responses that you're looking for. So floor back to you, Keith. Thank you.
Thank you. So yeah, so the way we assess certification is not just the knowledge base. And again, we're not doing a skills assessment here. We talked about it. It's really difficult to do at scale. I mean, you can't, if you have 100 people applying, you need to assess skills. That's a career to just run around and do that. So it really is knowledge and documentation of skills and experience. And we really do, again, we expect a contribution to the field. If you're sitting in your office writing plans and which is great, that needs to happen. But in order to get this certification, you need to make a contribution to the field, and we have many ways in which that can be done. But we do expect our folks to contribute back to where we came from, and that has not been a problem so far. I've worked with healthcare emergency managers since 2014, and if anything, they contribute a ton back to the field. This is not a stretch for anybody that's working with us, and we know that. So the third thing that we kind of thought was missing was a training standard, and we talked about this briefly at the beginning. Where do you go? How do you get that? I mean, even the list of documents that we put up on the screen a little bit ago, it's daunting, and some of them are enormous. Do I have to read that whole thing? Is all of that relevant? Or do I need pieces, parts of that? I mean, this is kind of where we are in terms of the training standards. What should we have? And is it available? I think is the second question. So right now we have a DRPH, doctorate in public health student who has, she's just getting her DRPH, but she has a wealth of experience in healthcare emergency management in California, as a matter of fact, in a large healthcare system. And what she's doing is she put together an exploratory survey and then some focus groups, and then she's going to put together a formalized survey soon. But her question is, what training have you had as to become a healthcare emergency manager? Was it helpful? Should other people have it? Is there stuff that's missing that you just learned on the job that we can potentially systematize so you don't have to learn it on the job? All of these training questions that we really don't have an answer to yet, she's helping us pull together. So we hope that's going to be helpful to folks. And in terms of training right now, what can we do in the meantime? Because then we can't wait for perfection. We have to move forward. So right now we do, the standard membership-based organization stuff. We do monthly webinars. We're going to do a virtual certification prep if people want it, which I think is going to be going to answer some of those questions in terms of what training do we have to get to where we need to go. And then at some point, in all our spare time, we're going to put together a certification study guide or book. I would really love to have a reference standard that we could refer people to and say, look, if you study this, you'll learn a ton, and it'll really help you in your job and moving forward in your position. That would be the ideal. But again, we'll get there. Specialized resources. There are, oh, go ahead, Misha. I saw you, you unmuted.
Yeah, I was going to say it took me just that split second longer to unmute myself than anticipated. So I've actually had 2 additional questions come through specific about, this piece of things. So one is talking about, like these components of education and where you're documenting your experience and training. So let's say you've taken specific like incident command courses or so on. Somebody in the chat referenced that when you go to get a CEM designation, so for anybody in the call list not familiar, that's through the International Association of Emergency Managers. Anything that's older than 10 years can't be used as a part of this application process. So they were just curious about if there's any time limits or restrictions around the pieces of experience and education that you'd be putting forward.
Yeah, we actually kind of expect those. So if you're going for the mastery level, right, you have to have 10 years of experience. We expect you to be able to document that experience within that 10 years. If there are exceptions, there are exceptions. I mean, we'll examine those on a case by case basis. But yeah, for the most part, there's nothing really too young or too new. And really, we haven't seen anything where people in our field are saying they did something 15 years ago. Can I apply this? They're pretty active. they're mostly it's stuff they did last week is really kind of what we're seeing a lot more of. COVID slowed us down a little bit. There wasn't a lot of training during that. There were a lot of exercises that didn't get done, of course, but they can certainly document their response experience. So it's right now, we don't have that limit because we really haven't had an issue with it.
Then I have one more follow-up question. So not talking about the time frame as far as the application to be considered, but how long does this certification last? So I know this is all a new process. So again, in case anybody missed it and joining, this has been, in the works for some time, but is fairly new to have rolled out. So is there an anticipated time frame for the validity of the certification?
Yeah, again, we're not making this easy. You are expected to get continuing education credits every year. And it's not a rolling 2 or 3 year average. It's you need to stay up on this field. Like our field is wide. We have a huge breadth of information we need to stay up on. And like I said earlier, couldn't spell cybersecurity 5 years ago. Now I know more about it than I ever wanted to. We have to continue to do that stuff. I mean, even some of the stuff with equity and inclusion. I mean, we've been, of course, we've needed to do that for a long time, but there's new information coming out all the time because we're just getting more information. So it's really important for people to stay up to date on that. So we expect an annual continuing education for us.
That's great. I think that's good for now. You can carry on, but I'll keep monitoring the Q&A, folks.
Awesome. Thank you. So specialized resources, and there are a ton of resources out there for emergency management, but not so much for healthcare. As a matter of fact, I was just reading a student's their kind of master's paper this morning and talking about what's out there, what they were looking at, what is out there in terms of planning or helping to conduct a evacuation of a hospital, specifically a hospital. And when you look at that, there's so much specificity in terms of what kind of hospital or how many patients you have or what type of patients you have and all that stuff, that he had a difficult time coming up with specific recommendations. So specialized resources are one of those things that I think our field needs to have more tools in. Now, don't get me wrong. If you're familiar with an organization called Asper Tracy, the Asper is Assistant Secretary for Preparedness and Response. Actually, no, I think that's the old definition of, never mind, ASPR, ASPR. Tracie, TRACIE. Those, they have a database that has a ton of information specific to healthcare emergency management. So they have all kinds of resources in there. I think one of the difficulties we had with that was that there's so many resources in there that it's hard to find stuff. Not that we expect them to take anything off, don't get me wrong. It's a great database to have all of that information in, and we really appreciate everything they do. Administration for Strategic Preparedness and Response. Thank you very much. I'm old. I don't remember stuff anymore. So that's perfect. But we did notice that there were a couple of gaps. And one of those is kind of and one of the questions we had from our members was, do you guys have a job description template? We need to hire another healthcare emergency manager. We don't know what qualifications we think they should have. So we did create that. And again, we don't do any of this stuff in a vacuum. We have multiple members, not only help us build these things, but also review these things. So it's not, the world according to Keith. This is the world according to healthcare emergency managers. Nobody cares about the world according to Keith. We need input from you people on the phone or on the Zoom. See, I'm old. It's a phone. I don't know how that came out of my mouth, but it did. Tools specific to healthcare emergency managers. And again, this evacuation checklist tool is one that we have a student that's actually trying to come up with a framework for that. And all of those specialized things that we need for healthcare that we don't necessarily have yet, or people aren't aware of yet. It may be buried in ASPR Tracie, or there may be 20 of them in ASPR Tracie, and they all say different things, or maybe they all agree. We don't know. That's one of the, those are the types of things that we need to kind of sift through. We do have what we call a monthly collaborate with colleagues. And I consider this kind of, this slide is just really showing my age. I consider this the water cooler conversation of AHEP. And if you don't know what a water cooler is, it's an actual, it's a thing full of water where you could get water out of that wasn't a sink. I don't know why we had them. We just did. But it's kind of that gathering around and having a chat. So every month we give members an opportunity to just get online and chat. And the amount of fantastic resources that members have that nobody else knows about is astonishing. People are doing great work out there, and it's really hard to share that with everyone. So this gives us an opportunity to do that. And when they're good, we then post them on the website. Other people need to know about these. And we put them in our newsletter and say, look what Fred discovered or put together. This thing's fantastic. So that monthly collaborate with colleagues for us is really important because we have the people in our immediate area, but there's all kinds of good stuff going out that people are really excited about and do great work on. The other thing that we do is our annual conference. And I bring that up for two reasons. One is that we're making the annual conference fit with professional standards. We're trying to make sure that our conference addresses what we think are the base and advanced competencies of a healthcare emergency manager. So we actually have people apply for presentations within those categories. If it doesn't fit within those categories, it's not on the top of the list. And the other thing that we do is we are very strategic and intentional about building in collaboration time. Now, the introverts that attend our conference hate this part because we make them talk, right? And I'm one of them. I'm exhausted by human interaction. But it's really important. That's where you get all of that information. That's where you get those tools. That's where you get that. Here's the thing that I did that worked. Here's the thing that I worked. Don't do this because that didn't work at all. That's where you get all of that, is from those conversations. We are very intentional about building that into the conference. So again, just another way that we're trying to make sure that those specialized resources are shared. Even if you don't have a presentation at the conference, you still get an opportunity to share what you're doing with other professionals in the field. And we think that's incredibly valuable and needed in our world. And then we have industry standards, which we are just starting to work our way into. Industry standards are really few and far between for the professional, for the facility, You can't spit without hitting an industry standard for the facilities, right? I mean, Health Standards Organization in Canada, Joint Commission, DNV, CMS here in the US. All of those things have lots of things that we need to do as a facility, but very little in terms of what our managers, healthcare emergency managers, need to know or need to have or need to be able to do. So we're just starting to delve into that. The things we put together had to come first. We had to have professional standards first before we could go to an organization and say, do you think emergency managers should follow these standards or not? We had to have a certification before we could really talk about, okay, this is how we think people can be identified as being knowledgeable in this field. And now that we have both of those things rolling out, we can start talking about, okay, let's start talking to the industry about making sure that the people in our field are not, they can be other duties as assigned, but boy, you can't have a part-time infection control person that's not certified. Why do we allow that with healthcare emergency managers? Because when things are bad, we need skilled, qualified people leading our charge. And we have many of those, but we don't have a great way for C-suites and for other people to look at it and say, oh, they have that designation. Great, we're good. And that's our goal. We're trying to professionalize our profession in a strategic, systematic, intentional way. Christy and I, my co-founder, Christy and I often joke about there are certifications out there that kind of feel like they were built in somebody's garage. They took some knowledge, they took some information, and they put together an exam and checked the box. And that's just, I work at a university. That's not going to fly. You got to have this based on logic and intent and what is good for the industry and what is good for the professional. I guarantee you, nobody's retiring on this process. This is not Keith's retirement plan. This is a labor of love for all of us within AHEP and people like Andrew and Rachel in Canada. They've donated countless hours to this process to help our field, and that's the goal. Is let's move our field forward. Okay, I need to stop, or I could.
You can keep going, Keith. We've still got a few more minutes here, so I have a question in the chat that might require you to go back to your slide of all the different competencies. So I admit I was a little sluggish in relaying this one, and I'm trying to recall what you had on the slide. Okay. So what got raised was, they appreciated the inclusion of the social determinants of health, but one thing that they didn't actually see on the list was conducting program, incident, or exercise evaluations and reviews. So is there an interest in including competencies that relate to reviewing and evaluating, using tools like after action review process and so on?
Yeah. So we do include exercise design and execution. And I would say that, evaluation and after action reports and actually doing something about your after action reports is included within that competency. So yeah, that's a big one for me. If this is how we demonstrate that what we do works, is exercises. We have no other kind of standard for that. So yeah, we need to be good at this. Great question.
And then, yeah, and if it's applying to real life response, then perhaps it falls under tools to facilitate maybe under recovery as a part of kind of debriefing process. I'm trying to picture where that might fit as far as not being its own category, but it's actually maybe embedded as a part of kind of the debriefing and the review and evaluation process into a couple.
Yeah, that's another good question. You're right. It's not specifically spelled out in this list of 14, but I would consider that as part of response operations. Is once you have that response, you need to do that after action report and after action review and assign tasks, disseminate that information to the C-suite, the people that are responsible for recovery. I would consider that a part of response operations, but I do think that the recovery component in general is soft in this version of the competencies, and something we need to beef up in the next round. I think recovery, how do I say this? I have a very bad filter, so I'm just gonna let it go. I think recovery is under-researched, underutilized, underexplained, understood in our industry. I think in emergency management in general, right? I mean, we talk, and then you have recovery. Done. We need to do better. So I totally agree. We need to make sure that that's within there, and specifically within there, and that we find ways to make us good at that.
Then I have a question still that maybe I'm not interpreting it completely correctly in the Q&A, but they were listing sort of the competencies list that we have here and wondering how that's paired with the skills levels with those different certifications. So it's not that we're picking and choosing, it's using all of these, but at different levels as far as how you're being paired with a basic versus a master's.
Yeah, and I think that's one of the things that we need to get better at in terms of AHAP is, right now the exam covers all 14 of these categories. That's how we're assessing the knowledge in these 14 categories. We do not necessarily assess skills in supply chain continuity. We do have questions on it. We don't specifically ask people to demonstrate their skill in supply chain recovery. Like, we don't say, submit the exercise you conducted on supply chain recovery. We don't get into that level of specificity on these 14 competencies. But no, I agree that we consider these the base. I think as we go on, we'll have to have conversations about whether we add to this or we kind of recompartmentalize how things fit together within this.
Then I don't think I have any other questions in the Q&A. I'll give it another minute here just to see if anything else populates. So again, the chat's been active, so I've appreciated a lot of that back and forth. For anybody that was maybe a late joiner, you might have also noticed there's a few links that Keith mentioned during his presentation that have been put into the chat area. I'm just quickly checking. I think maybe one more question has populated in here. Okay. So one more question then perhaps. So we see somebody saying, there's a number of different stakeholders that are in healthcare emergency management. Are you targeting more than just emergency managers with this certification? And if so, are there other stakeholders that are being considered?
Yeah, we've had that question from numerous people, and I'm not saying this in a disparaging way at all, but most of them were vendors who worked in this field and then took their expertise and skills to med sled sales or emergency management software sales, or whatever the case might be. But they're still kind of committed to this field, and they want to know if they can still apply. And we're actually working on that right now. We don't have a solid criteria for that. Like, if you haven't worked in a hospital for 10 years, but you've been working for WebEOC, what does that do to your application process? We don't have an answer to that yet. We're focusing on active healthcare emergency managers right now, but that is absolutely an area that we have to start to address.
Okay, so I don't have any further questions in the chat. Definitely would recommend folks go to the website. I was going to say, Keith, if you want to flash that last slide again. So a comment, you can certainly reach out via the link that Keith has there. So if you have any targeted questions for AHEP, those will be filtered. Also, Francesco has, given his email address in the chat as well. So if you'd like to reach out to CFAL York's coordinator, we can also filter any additional questions that come to mind. I greatly appreciate that Keith was nimble and flexible in being able to answer questions as they were coming through and coming to mind during his presentation. Also, you'll see in the chat that Francesco has highlighted. Some folks did ask if the slides were going to be made available, but just reminding everybody on the call that the session's recorded. So we'll hopefully have this up and available soon on our YouTube, and then you can refer back to all these points that Keith was talking about today, really about the importance of this process and the value that this organization, I think, is adding to our segment of the emergency management field. So Keith, I want to say thank you very much. I know you're very busy. For anybody on the call that isn't aware, again, the conference just ended. So I appreciate having you come and represent not just the association, but really highlighting, as you said, this is a passion project. And you're recognizing that it's a living process that's continuing to evolve and grow. And this is a great opportunity for folks that are in healthcare emergency management to kind of tap into some of these resources and be a part of the ground floor as far as seeing where this certification process is going to go for all of us. So thank you again for sharing with us today, Keith. Really appreciate, your passion for all of this. And I think this is a really valuable addition to the series. So I think with that, I get to flip it back to Francesco for our final closing statements.
Yep, thank you so much. I just want to echo your thanks first. Thank you, Misha, for helping organize this session and all of our sessions. And thank you, Keith, for that great presentation and for answering all of the questions our audience had. And of course, thank you to our audience for taking the time to be here, participate, ask questions. And of course, we can't do this without our audience. So thank you very much to all those who support what we are doing. And then just to close it off, I just want to remind everyone this is a monthly speaker series. So the next session will be on April 3rd, same time, 12 p.m. Eastern Standard Time, or Eastern Daylight Time at that point. And we'll be having a couple of speakers from Niagara Health. So if that is of interest to you, please mark that off on your calendar, share the event with everybody in your network. Registrations are always open and free for our speaker series. So with that, one last big thank you to everybody for being here. And I hope everyone has a great day.